Hello, everybody. We'll begin in about 4 minutes. Thank you for joining us. Do note the technical information in the in-chat panel if you're having any technical difficulties. Good morning, everyone. I'm Mark Weeks, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled, "The ED is Ground Zero for This Epidemic, Face-to-Face with This Crisis and Winning." This webinar is being made available through a collaboration of the Office of the State Court Administrator and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and those options are posted in the in-chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording, go to www.fata.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FATA produces many webinars and workshops through the support of the Florida Department of Child and Family Services and the Office of the State Court Administrator. To help participants track credits earned through attendance, we host an online community that provides personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will redirect everyone to an evaluation form on the FATA website. You will first need to register or sign into your account to complete the evaluation. Information you provide FATA as part of the registration remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual personal development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits to access your statement of credit. Do note that the evaluation will close midnight on Monday, November the 18th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certified Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrivals and departures of attendees and provides a report upon completion of this event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. Dr. Pomm is a board-certified psychiatric, addiction psychiatric, and addiction medicine. He is also a certified medical review officer. Dr. Pomm served on the Governor's Commission on Mental Health and Substance Abuse. In 1992, he began working on the Impaired Professionals Program of the state of Florida, the Professionals Resource Program from 1998 until 2011. He served as medical director for this organization. PRN serves 29 healthcare boards and councils on matters relating to healthcare professionals impairment. Also, from 1994 until 2010, Dr. Pomm was an expert consultant on the Florida Board of Bar Examiners. He served as medical director for River Region Human Services until 1994 until 2017. Dr. Pomm serves as Chief Medical Officer for Gateway Community Services in Jacksonville. And now I'd like to welcome our presenter, Dr. Pomm. I will now turn the presentation over to you. Or not. We had some technical difficulties with Dr. Pomm. His power just went out, I have just been informed. We will be delayed about 5 minutes.
after the intermission. Hello?
Dr. Pomm, are you there?
Yes, I am.
Perfect. All right. Since your power has gone out, what we're going to do is I'm going to go through, if you can, pull up your PowerPoint slides, or if you know them, and we will go through and I will move the slides and progress them for you. And you'll just say slide when you want to change the slide.
Oh, actually, let me go ahead and do this then. I'm going to pull up the PowerPoint.
Again, we apologize for this. Dr. Pomm's power has gone out at the exact time of the webinar, conveniently enough. So thank you for bearing with us, audience listeners. We'll get this straightened out. And everybody in the attending, you can hear Dr. Pomm as well, yes? Oh, what happened to him?
I'm here.
Okay, he's still there. Good.
Yes, I'm here, and this is going to be a very strange proposition, but we can do this.
We got to roll with the punches sometimes.
I won't be able to see any questions.
All right, I'll relay the questions to you as they come.
Okay.
Yeah.
All right. Very good. Okay. Well, you tell me when we're ready to start.
All right. Well, we're on slide 1 right now. And if you want to go through your presentation, when you're done with the slide, you'll just say slide, and I'll move to the next slide.
Okay. Very good. All right. Well, this is all a very strange occurrence. Like Mike said, the minute he was getting ready to move it over to me, my power went down. So we're going to try and do it this way. Hopefully everyone can hear me. Let me just start with a few introductory remarks. I'm not going to be going over reading the learning objectives. I know you all can read those yourselves. And Mike, if you can move on to the opiate slide, which is the third one. I just want to say that I know some of you maybe have heard some of this before. I don't think many of you at all have heard the entire presentation. Even the parts that you might have heard have evolved. It still surprises me to this day that people get confused as to what epidemic we're talking about. So I'd like to start, before we get to the actual ED portion, I'd like to start with getting us all on the same page as to exactly what we're talking about, and not only what we're talking about, but the depth of the actual problem that we're dealing with, which is not getting any better, even though in some ways it looks like it is. We'll talk about that in detail as we move along in the presentation. So bear with me as I move through some of the historical things. I'll try and make this a little interesting. It's always challenging doing a webinar. It's even a little more challenging right now, given there's no power here. But moving along, let's start with the slide opioids and opiates. The reason I put this slide in there is because of the transition historically from DSM-2 to 3 to 4. We had always differentiated between opioids and opiates. We used to say that opioids were the synthetic and semi-synthetic drugs, where opiates were the naturally born drugs out of morphine and codeine. DSM-5 decided to change that and put everything under the category of opioids. So opioids now encompasses all of the drugs we're talking about in the opiate category. And we'll get into some of those specific drugs in just a second. Moving along, I just want to go back in time a bit, because it amazes me that I'll be talking about the opioid epidemic and people are still thinking about the pills. Now, the pills are significant in the historical version of this epidemic. They're significant in their continued use and somewhat of a gateway to where we're at, but not as significant as it used to be. And I'll explain that as we move along. Moving as far back historically as probably is relevant for this conversation. In 1971, President Richard Nixon officially declared a war on drugs. He was the first one that I know of. And what I hadn't known prior to creating this slide, that was in 1973, he created the DEA. He was the guy to coordinate the efforts of all other agencies. Actually, as I'm talking about this, I'm finding it very interesting. We're talking about Richard Nixon at the same time. There is an impeachment hearing going on. So I'm not sure if the universe is speaking in any direction one way or the other, because given all what I just said and the power outage, I'm not sure what it all means. Don't want to go there now, though. In 1984, Nancy Reagan launched her Just Say No campaign. Well, I was skeptical when she launched that campaign. Just Say No, yeah, it works for people possibly that are entertaining the thought of using drugs. The bottom line is once you develop the disease of chemical dependence, or substance use disorders, we now call it, saying no doesn't work. The disease has fully taken over the person's life, and really the drugs and the disease thinking are in total control, and saying no doesn't work. We don't hear this very much anymore, though it was certainly, the intent was good. In 1989, President George H.W. Bush, that's the first President Bush, presented a national drug control strategy that included the largest budget increase in U.S. history. Unfortunately, even though there were large seizures of drugs and many individuals imprisoned, we have continued to see an increase in drug use. Well, biggest reason, I think, at that point, and has continued to repeat itself throughout history, is because most of the money went to our criminal justice system. And as we all now know, even though the role of criminal justice is extremely important, it is not the answer. It's part of the solution. But and one of the reasons I actually give this part of the presentation is by continuing to repeat the history of how we got here. I'm hoping that we can learn from history and maybe not repeat the same things over and over again, expecting different results. As you all know, that is certainly the definition of insanity. And I'm not sure our political system is ready to evolve like that, but I keep hoping. Actually, to go a little further with that, the reality is people are starting to see that they can't jail their way out of this problem, that treatment is a necessary component. There is a little evolution I'm seeing, so I'm hoping that will yield some real honest-to-God fruit. And whoops, sorry about that. Next slide, which is abuse of prescription, number 5, please. Now, in 1995, Purdue Pharma developed OxyContin. This should be almost a household name at this point, OxyContin. Prior to that, we had oxycodone. And what they did was they developed a way of a person taking the oxycodone, which was typically prescribed in 5 milligram or 10 milligram tablets up to 3 times a day, as an example. And what they did was they packaged it in such a way that was slowly delivered over time. So they created pills with 20 milligrams of oxycodone, or 40 milligrams, or 60 milligrams, or 80 milligrams of oxycodone, which was slowly delivered over time in the body. Could be given 2 or 3 times a day. Problem is, their advertisement or their advertising campaign to the media, through the media, to the public, and even to the healthcare practitioners was this greatly reduced the addictive potential of oxycodone. Well, unfortunately, they weren't telling the truth. And in fact, I don't know if you know this, but you know, it's been over the it's been in the news quite a bit. Purdue Pharma is being sued a second time round regarding their false advertisement and the push they made toward getting this to the public as rapidly and as plentifully as possible. And in fact, I believe, I'm not mistaken when I say this, Purdue Pharma, the family that owns Purdue Pharma, is directly being sued. That happened just a few months ago, and right after they were directly sued, they declared bankruptcy. Now, I'm not a lawyer, and I'm curious to see how this is all going to pan out. There are a lot of other, by the way, there are a lot of other companies being sued also as states get together and organizations get together to sue the pharmaceutical industry behind the pill opioid epidemic. So with that false advertising and the big push to get as much OxyContin out as possible to as many people as possible, in 1999, the pill opioid epidemic actually began. Now, this was a really devastating time, or the beginning of a devastating time from which we've really never come out. When the focus became on what the issues were with OxyContin, and more pressure was put on physicians and organized medicine regarding the overprescribing of OxyContin, interestingly, what happened was that started fading off, and the abuse of oxycodone started rising. Now, let me back up just a brief second also before I make this transition to show further insanity in what's going on here. The first President Bush, after he declared war on, drug abuse, he showed a graph of how they're winning the war against heroin, because prior to OxyContin, heroin was prolific throughout the country. What he didn't show you was the other graph, where OxyContin use was on the rise and was far surpassing, actually, the prior abuse of heroin. So, we weren't really winning any war. OxyContin was winning for sure. But then when the pressure, as I was just getting ready to say, came down on OxyContin, what happened was the abuse of oxycodone went up, the parent compound. Then the focus got on to oxycodone and how that's not doing great and doctors are prescribing way too much. So when that pressure came on, the doctors started prescribing methadone. And, basically these pills were being prescribed in hundreds at a time, along with benzodiazepines, which we'll talk about in just a minute, specifically Xanax. People walking out with basically bags full of medicine, all addictive. And by the way, just to let you know, the methadone that was being abused at that time was actually not the methadone coming from methadone clinics. I actually called the head medical examiner of the state, the University of Florida, state ME's office, and I spoke with him directly because I was very concerned. And I asked him, well, how do you know this is methadone prescribed as opposed to methadone coming from the clinics? Because if it was methadone coming from the clinics, that at that point, by the way, prior to buprenorphine, methadone was the treatment of choice for opiate addiction for many, many individuals in this country. And that would be devastating for that treatment alternative at the time. He specifically said, no, it is actually prescribed methadone from the pain doctors. How do you know that? He traced every single prescription back. Now, the interesting part to that is he said, I want to highlight that not only is it methadone being prescribed by the pain doctors, but greater than 90% of those who died from a methadone overdose also had benzodiazepines in their system. And greater than 98% of the benzodiazepines actually Xanax. I already sort of knew that because we were already doing urine drug testing and we could see what was going on with this fluctuation of what's being abused at the time. And I said to him, I said, what is going on here? We're blaming only the opioids for these deaths. The reality is Xanax has contributed very greatly to the deaths. And he and I just sort of commiserated and threw our hands up. We didn't understand why there wasn't any focus on Xanax, on the benzodiazepines. And by the way, that has gone on, and it's still an ongoing problem. And it wasn't until, interestingly, and I'm not behind this at all, and I'm not saying anything about which news organization. CNN, just a few weeks ago, had a special, and you can find it on YouTube, on benzodiazepines, finally highlighting the problem benzodiazepines have been for the last several decades. Despite my yelling and screaming, and no one really listened, despite other people yelling and screaming, it was pretty much an ignored issue, but it's still a significant issue. And we don't have time to get into any great details about that, but I did want to highlight it. Well, when the focus then got on methadone, what happened was it changed back to oxycodone. You know, I mean, what were we chasing here? We're coming down on certain drugs, and it's just shifting. It's like coming down on the drugs is going to change the disease of chemical dependence. It's going to change and cure these opioid addicts. No. Well, I think everyone in the field knows that's not the way it works. And again, another case of, you keep doing the same thing over and over again, expecting different results. Well, yeah, it's not just the addicts and alcoholics that have the same thinking and same behavior. I think we all do too, all the way up to the top. And I don't want to make this a political discussion, please. Anyway, so interesting, in 2010, Florida became the pill mill capital of the U.S. Florida had 900 unregulated pain clinics. 90 of the top 110 oxycodone prescribing docs were in Florida. Of the top 50 dispensing clinics in the U.S., 49 were in Florida. What was going on? All the neighboring states had already developed a centralized pharmacy registry that every prescription written by doctors was put into this registry. So everything was tracked, and the doctors were required to enter their prescriptions in, creating much more accountability. All I can say is this: Florida did not adopt this. We'll talk about that in just a quick minute. They, because of that, it was a lot easier to come to Florida to get the prescription for these drugs. And the neighboring states came, people from the neighboring states came in busloads to get their oxycodone or OxyContin prescriptions along with their Xanax, and that was called the OxyContin Express. Let's move on to the next slide, please. Number 6. Can you hear me?
Oh, yes. I got you.
Yeah, number 6. Now, organized medicine had some role in this. They were behind pushing the medications. People should not be leaving the hospitals or the clinics or the doctor's office without having a state of being pain-free, which is, by the way, not a reasonable expectation, but that's what was coming through from organized medicine and JACO, the Joint Commission, who basically certifies the overseers of hospitals. And they created this pain scale, and they call it the fit vital sign. Oh, what a mistake. Oh, my gosh. So if you basically didn't come out with a bag full of pills with a smile on your face, the doctor wasn't doing a good job. What? And that's the direction we were heading. And we had gotten there and arrived. And really, this is where the entire pill opioid addiction took off and running. I just got to say this, that organized medicine was pushing and pushing doctors, hospitals, clinics to help people get pain-free, to prescribe these medications. They're pushing really, really hard. A lot of educational push as well. Since fentanyl has come around and the other opioid epidemic, which we're going to get into in just a minute, has come to our doorstep, actually it's fully in our house, they've been silent. Nothing at all. Moving on. Here we go. I was medical director of the Impaired Professionals Program. In that role, I was consultant to the boards of medicine, osteopathic medicine, and pharmacy, and many of the other boards. But there was a big push from the boards to get or incorporate in this state a centralized pharmacy registry, as there were in other states, to try and stop the OxyContin Express. We pushed and pushed and pushed. When we first started pushing to develop this, it was around the same time, by the way, that that Purdue was first sued. That was the first suit. We're now into the second suit. And through that suit, they were going to pay for it. For 10 years, we pushed, and it kept getting rejected by our legislature. I don't know all the ins and outs about that, but it was really quite disturbing. And by the time they finally approved it, which became e-force, 10 people were dying a day. As I said, when we first started pushing, it was 5 deaths a day. Then it became 10 per day. And my power is just coming on. That's good news. Now, I'm sorry. Can you give me a quick second here? I have to mute it because with my power coming on, I get a funny noise. I'll be back in 1 second.
All right, I'll mute you. Oh, if you muted him. Thank you for listeners for rolling with the punches with us. Dr. Pomm will be on in just a second as soon as he gets booted back up.
Okay, I'm back.
All right, perfect. We're on slide 7.
Sorry about that. So we are on slide 7, yes. So what also happened that time, the 3 boards, Board of Medicine, Board of Pharmacy, and Board of Osteopathic Medicine, created a pain rule. And it was very interesting then. Despite the problems, I was fighting really hard for this pain rule to go into effect. And it was interesting the pushback I got, the indoctrination from making sure everyone was quote-unquote pain-free became quite a business for all the doctors. And, yeah, I'm sure people aren't going to like what I have to say, but I remember sitting in a room with all the pain, many of the representative pain doctors throughout the state. And I thought that as part of the pain rule should be a pill count, meaning that when an individual comes back for the next appointment or intermittently randomly calling them to come in, they should bring their medications with them and count the pills to make sure that they're taking them as prescribed. I got such pushback. I was taken back. And of course, that was not put in the rule. But I mean, the rule itself is relatively good. So what ends up happening was, as we move along from 2011 onward, I guess the black market folks felt a little gypped because they were being pushed right out of the market. Heroin use had plummeted because the pill opioids were so cheap. I mean, people could go to doctors for basically just a few bucks and get a lot of pills. So what happened was the black market folks cut the cost of heroin. Now, in about between 2013 and 2014, fentanyl started arriving on the scene, and slowly but surely, and this was totally unpredictable, fentanyl arrived on the scene. Fentanyl was being put into heroin. And that then became the beginning of our current opioid epidemic. Just want to move ahead relatively quickly, and I'll come back to more of this in a little bit. Moving along, so obviously that started increasing, and I'm going to give you some data, bring us up to date on this. And just to say that in 2018, and we'll get into a little more detail near the end of this presentation, our state introduced House Bill 21. House Bill 21 was a good start, but it only spoke to the pill opioid epidemic. I appeared before the Senate subcommittee, and they asked for my input on House Bill 21, and I gave it to them. I also spoke with my local medical society and other folks around the state, and I said, this is a great bill in many respects, though we needed it in like 1999, 2000. And it doesn't speak to fentanyl. And that's the problem, and that's what's killing people today. But that sort of fell on deaf ears. But again, I will get into more detail. Next slide, please. Going through a bit of data. So, as I mentioned, fentanyl use was starting to be seen on the rise. And during 2013, 2014, we actually saw an increase of 426% of fentanyl. Okay? And at that point, overdose deaths started increasing up to 79%. Now, we'll get into more relevant data or present data in just a second. In March and October 2015, the DEA and the CDC, respectively, issued nationwide alerts identifying illicitly manufactured fentanyl being made in a lab and being brought into this country, that being a public threat, meaning that now, as I had mentioned, IMFs, illicitly manufactured fentanyl, being mixed in unknown concentrations with heroin. Again, we'll get into those details in a second. We were a little hopeful in 2016 because actually there seemed to be a decrease in the amount of fentanyl seized, but it was because there was an increase in one of the IMFs called furanylfentanyl. Furanylfentanyl is an analog of fentanyl. It's less potent, but doesn't reverse as easy with the reversal agents we have like Narcan. I'm sure many of you or most of you know what that is. Basically, if someone overdoses, we give them Narcan. It brings them back and helps us revive them and bring them back to life. And unfortunately, furanylfentanyl was not responding as well to furanylfentanyl. And this got to the Midwest, and I was waiting for it to get to Florida, and I really have only seen very little of that. Moving to the next one. So there are actually 9 others, probably more now, illicitly manufactured fentanyls, or again, analogs of fentanyl. We'll talk a little bit more about this in a few minutes, but fentanyl itself is 50 to 100 times more potent than morphine. And then there was also carfentanil, greater than 10,000 times more potent than morphine. The question of the day, actually back 2 years ago, the question of the day was this the current generation's AIDS crisis? Because in 2015, 52,000 people died of drug overdoses. The peak year for AIDS-related deaths was 51,000 in 1995. With our present crisis, there is no end in sight. Moving on to the next. Let's continue with our data. According to the American Medical Association, the epidemic continued to grow through 2025. This is scary. Let me just say that I've been in this field for 30 plus years, and never in my worst nightmares did I ever imagine something like this happening, and it continues to get worse. So this is going to be somewhat of a depressing talk as we move along. The U.S. could see record numbers of deaths, up to 200,000 individuals per year. According to the CDC, in 2016, there were 63,632 deaths. In 2017, there were 70,237 deaths. Next slide. Locally in Florida, there were 5,725 opioid-related deaths in Florida in 2016. I'm just going to say that most of that was from fentanyl. That was an increase of 35% from the prior year. And in 2017, it increased another 8%. 17 people were dying a day. Now, when you look at literature, especially substance use literature, you're really lucky to find upward of 2012, 2013 is up-to-date literature. I'm going to bring us up through this presentation to present day. So just be patient in a minute, for a couple more minutes. Of those deaths in 2017, heroin increased by 1%, fentanyl increased by 25%, and fentanyl analogs increased by 65%. That is crazy making. That is just insane. This stuff was just killing people. Really sort of weird, though, as for those of you who are in the field, which I'm sure most are, it's always been incredible to me, the mind of the addict, because when there are deaths, you might hear of someone in the entertainment industry who died from an overdose of heroin. And what happens is the addicted population say, oh, I want to get my hands on that stuff. Oh, wow. So the greater the number of deaths, it did not deter individuals from using the darn drug at all. And again, I'm going to get into a little bit of that in a few more minutes. Next slide, local in Florida, they're continuing. There were 5, I want to move on to the next slide, the local Duval County. Sorry about that. We were really focused here in Duval County with the issues at hand. Our city council really got on board and were very concerned. In 2015, Jacksonville Fire and Rescue Department responded to 2,114 calls, overdose calls. In 2016, they responded to 3,114. 911 calls had tripled. In 2015, cost of transporting OD victims was almost $2 million. In 2016, it went up to over $3 million, with projections moving toward the $5 million mark in 2017. They were transporting one overdose every 2 hours. Just imagine that. That's just a phenomenal statistic, a really sad statistic. Naloxone, which is Narcan, used by paramedics, had increased 5-fold, taking up 1/10 of the medical supply budget spent on naloxone. This was a call to arms from our city council, which we are going to get into and how they responded to that. Incredibly, in 2016, I want you to hear this, Duval County had 106 murders and 464 overdose deaths. What was the media paying attention to? The murders, not the overdose death. It's like, what is going on with our society? Why are we not paying attention to this? The age distribution of drug-related deaths in Duval County, 20 to 60 years old. The demographics were all over the place, with 86.9% being Caucasian, and that, we're going to find out in a little while, is shifting a bit. The morgue at that time was continually over capacity. I'm not exaggerating when I say the bodies were piling up. I'm not exaggerating when I say that the morgue told the hospitals, hold on to the bodies, we can't take anymore. That's how bad it was. They had to build a new building, which they did. Duval County had the second highest in the state for neonatal abstinence cases in 2016. There was obviously an increase in positive fentanyl found in drug screens. And I just want to say, Gateway, where I work, we began testing for fentanyl in about 2016. Approximately 2016. We were seeing 100% of positive heroin urines being also positive for fentanyl. 100%, and that has not changed. You can see in this slide how up through 2016, the deaths for just heroin, sure, they increased. But when you look at the synthetics, that would be the purple line going up, that would be fentanyl. Look how that took off from 2014 up to 2016 in this graph, okay? And you can see overall for Florida how they jumped again 2014 to 2016. It jumped up again because of fentanyl, our epidemic. That's the epidemic that's killing people today and has been since 2016. At present, there are 140 deaths per day in the U.S. from this epidemic. 2 deaths per day in Duval County. This is absolutely incredible. I want to show you this chart. This is from Jacksonville Fire and Rescue. And by the way, when I talk about Jacksonville Fire and Rescue, don't think if you're not in Duval County, you're not having this problem. Okay, there is some degree, if not a total correlation, throughout the entire state in every county. You might be saying, well, I only have a meth problem here, we don't have a fentanyl problem, or whatever you might say. The vast majority of folks out there still are not testing for fentanyl, so you don't really know. And I've been pushing hard on the need to test for fentanyl to know what's going on. And again, we'll get into that in just a few minutes. Okay, now you see with this slide, this is slide number 17, how it rose, I believe, in about 2016, 2017 was peaking out. I'll get into why it dropped off, but you can see now, as we move into 2019, which is the tail end on the right side, that we're creeping back up. And there are reasons for that, which we will get into. This is basically over 911 calls received, Narcan doses given, treated as an overdose, and the basic trend, which is that dashed line moving up. Again, it is moving up as an overall trend. And you can see that all the actual lines are pretty much increasing. Next slide. One of the problems associated with this is obviously pregnant women who are opioid dependent and using fentanyl. Opioid use during pregnancy can result in drug withdrawal syndrome in newborns. That's neonatal abstinence syndrome. Okay, it's really costly hospital stay. Showed approximately 32,000 people. I'm sorry, this is in 2014. 32,000 babies were born with this syndrome in the United States. In 2014, that was a 5-fold increase since 2004. Every 15 minutes, a baby is born suffering from opioid withdrawal. That took us through 2014, which is really the beginning of the fentanyl epidemic. And you can only imagine how bad it has gotten. I'm sure you have heard. And, of course, it's devastated DCF in terms of what's happening with these families, the mothers that can't take care of these kids. In fact, let me just say, in 2016 to 2019, the number of babies with neonatal addiction at UF Health in Jacksonville increased from 10 per 1,000 to 15 to 16 per 1,000 births. Average length of stay for these poor neonates is 16 to 17 days and up to 2 months, and the cost is horrific. And if you would like, no, okay. And in fact, most of these births are unintended pregnancies, which is a very sad statement. Go on to the next slide, please. Now, how common is opioid dependence? You know, we've thrown this number around for a long time. Approximately 2.5 million Americans are dependent on prescription painkillers, right? Or heroin. That was in 2012. You all now know that in 2012, fentanyl hadn't gotten here yet. You all know also, because of what we've talked about, how the pills were the biggest epidemic at that time, and heroin had already fallen off. All the data I've given you so far, well, guess what? Not accurate at all. We don't have a clue what the real numbers are. The emergency department data is not accurate because people come in and they're being treated or they die from what? Respiratory depression, they don't say overdose. Or endocarditis, they don't say overdose. Or whatever other condition it is, that's a sequela, a consequence of the opioid being used, or the drugs being used, but they don't label it as such. Exact same in the hospitals. And in the morgue data, not everyone goes to the morgue, number one. Well, if you know that, no, not everyone goes to the morgue, and everyone going to the morgue don't always necessarily get tested. We don't have a clue. It is worse than we know. I can't even imagine how bad it really is. Okay, let's move on to the next slide, please. Let's just briefly look at this just to make sure we're on the same page regarding how this is all working in our brain. We are moving fairly rapidly towards a break. I think you all have heard of dopamine, neurotransmitter. Basically, our bodies are full of nerves throughout, miles and miles of nerves. They interact with each other. They communicate with each other. We have nerves that are telling us where we are in time and space, give us our balance, be able to help me talk, move my hands while I'm talking, look, see, move my eyes, all that stuff. In the meantime, it's also helping our bodies function. And one of the functions of our bodies is, as well, it's feeling good at any given point in time. Now, in order to communicate across the way, you can't just have one nerve going all the way. It branches out, junctions. All these nerves transmit their impulses through, like little electrical stuff going through the neurons. And when it hits a junction point, it actually hits a gap. That's called a synapse. In order to get over the gap to continue transmission to whatever it wants to continue it with, it creates a neurotransmitter. This neurotransmitter travels through the gap, hooks up to the next recipient neuron in order to continue that transmission. And in this case, we're talking about dopamine is that neurotransmitter, which allows the transmission actually in one particular area of the brain, if we move on to 21, and that's called the pleasure center. I'm not going to get into the details of that, but this is where we feel good. This is what makes us feel good. And for the most part, it is governed by dopamine. Moving on to the next slide, it's not just drugs, feeling good. When you're hungry and you eat, you feel satiated, you get an increase in dopamine. Fluids, when you're thirsty, you drink, you get an increase in dopamine. Actually, when fight or flight. Also, when you flirt, and that's one of the reasons, and we don't have time to get into this, but, we tell people, hey, don't be flirting or get into a relationship first year of recovery, because that increases dopamine. And interestingly, when it increases dopamine, our brains don't differentiate between the dopamine that's caused from flirting versus the dopamine that's caused from drugs. And it all invariably takes us back to our drug of choice. Let's take a closer look with the next page, exactly what happens. You can see dopamine being created, and there is in the cell, the transmission is coming from the top down, and then here's the recipient cell at the bottom, and then you're creating the dopamine, and then you have dopamine receptors on the recipient cell. And if you go to the next slide, which is 24, we have a very efficient system. The dopamine is released, it hooks up with the dopamine receptor, and then once it's done its thing, it picks up the dopamine and recycles it. Very cool, actually. But now you see we have an internal opioid system called endorphins, also other things in Keplins, but we'll say endorphins is our own internal one. Endorphins will hook up with the opioid receptor, and then what happens is Once that hookup is complete, that triggers the release of dopamine from above, or wherever it is. It just happens to be on the slide above. Released, hooks up with a dopamine receptor, where it triggers the electronic impulse, the little electrical impulse down that next nerve, so it can continue that transmission. And when it's done its job, it's picked back up and recycled. And moving on to the, whoops, sorry about that, next slide. Neurophysiology, which basically just hones in. It's very similar. Here we have morphine. It's not made in our body. And when morphine comes into our body, it acts like our own internal opioid system. And it hooks up with the opioid receptor, actually called mu receptor. Don't have time to get into all that. Again, triggers the dopamine, and then we're off and running, and we're feeling good because of the release of dopamine in our limbic system or our pleasure center. Typically with the, flirting, food, and all the other stuff, we can move on to the next slide, please. Typically, you get dopamine release. You can see it. Now, this is cocaine, which is the most prolific push out of dopamine. However, all drugs of abuse cause so much more dopamine release in that gap, that synapse. Our bodies actually have to create even more receptors in order to keep up with it. And that's why the intensity of feeling that one gets, as you can see on the right side of the of this particular slide. All right, next slide, please. This I just want to say is up on your screen because there's an important point here. As you can see, hydrophilic and lipophilic, really lipophilic means it's more easily absorbed by fat in our body. And all of our nerve cells in our brain are sort of surrounded by some fat layer. So the more absorbable a drug is with fat, the quicker the onset of action. And fentanyl at the bottom happens to be the most absorbable by that. And in fact, the more rapid the absorption, the more rapid the onset of action, the more addictive the drug is. Now, this is transmucosal. That's in our cheek area, okay? With fentanyl, if you just put it in your cheek, the onset of analgesia is 5 to 10 minutes. When you shoot it, it's basically less than a minute. Duration of effect is only 1 to 2 hours. It is one of the fastest onsets of action that is known to mankind. And it is one of the most addictive substances. It is so potent and then leaves our system so quickly. The intensity of cravings and the intensity of withdrawal when it leaves our system is almost unbearable. Moving to the next slide, I'd already mentioned, which is slide 29, fentanyl is 50 to 100 times more potent than heroin. So what was happening was people would shoot, well, we'll get there in just a minute, just got ahead of myself. Basically playing Russian roulette with 5 chambers full. It'll kill you. It just takes a few grains. Carfentanil, so one of those analogs, is 5 to 10,000 times more potent than heroin. That you're just going to die. In fact, if you've heard of some sheriff's office, law enforcement officers and fire and rescue folks who have died, it has been quite often exposure to carfentanil. Just touching the skin, accidentally breathing some in, you just die. There are no ifs, ands, or buts about it. That carfentanil is what we used to know would be known as elephant tranquilizer. If you have a charging elephant coming at you and you shoot a dart at it with carfentanil, it drops the elephant. And we don't have a reversal agent for that. Basically, it's all over. So next slide. What happens now is person shooting up heroin, they're trucking along, they know how much they can shoot up, and that's been serving them horribly well. I use those words exactly. And then you add a little fentanyl in there. And remember, it's 50 to 100 times more potent. Well, now you're shooting up just as much as you were before, but now you've got this highly potent drug added into it, and you just basically die. And that's exactly what happens when you mix this, and it is hard to know how much fentanyl you're actually getting in there. And we'll get into some of the intricacies of that further down the line in this, as things have evolved significantly, even since the beginning of this epidemic in 2014, 15, and 16. It's just a death trap. And unfortunately, where we know that addiction hijacks the brain, fentanyl hijacks the mind, the body, and the soul, you're under the influence of one of the most potent drugs known to mankind, and you are totally impaired at the time. It only lasts, as we already talked, maybe an hour or two, and then you go into intense cravings, intense withdrawal symptoms. It's just unbearable. I actually had a patient who had been in recovery and relapsed on heroin/fentanyl. Dealer kicked her out of the car. She had already, by the way, had many of her friends die from overdoses, as I'm sure you know of many people out there who've died. And he kicked her out of the car. She rolled on her lawn and looked up, and there was her 13-year-old son looking at her. And she quickly swooped him up and sent him to the bedroom. And then she called her old sponsor and said, listen, I've got one bag left, and I need you to do me a favor. I'm going to shoot it up. Just make sure my son doesn't see my body. Death has no meaning. Things have gotten so crazy. Death has no meaning. Getting the drug is all that is wanted. Get to the drug. Relieve this horrible hijacking of the mind, the body, and the soul. And if I die along the way, it doesn't matter. And I hear this over and over again. It's such a sad story. Moving on to the next. As we all now know, this is an epidemic that is growing faster than we ever imagined. Costing lives and money is pushing the envelope of everything the system has to offer. We need a solution now. At this point, I'd like to take a 5-minute break, and we can come back, and I think hopefully we'll be technically working well. So I'll see you all back in 5 minutes. Thank you.
Yes, thank you, Dr. Pomm. And Dr. Pomm, please make sure your phone is fully charged. We're just going to continue with this methodology for the duration. And participants, we're going to be taking a 5-minute break. Thank you for bearing with us through our technical difficulties. And we'll be back at 11:11 sharp. Dr. Pomm, are you there?
Yes, I am.
Perfect. It's now 11:11. We're returning from break, and we're on slide 32.
Actually, slide 34. Oh, I'm sorry. No, I'm wrong. Slide 33.
33.
That's where we'll start.
All right. Protect, save, project save lives.
Yeah.
Yeah.
Okay. We ready for me to begin?
Oh, yes. Thank you.
Okay. Thanks, Mark. All right. So we left off bringing everyone up to the present day with this horrific crisis, which is actually going to be even worse as we move along. And now we're getting into the meat of the presentation regarding the emergency department, because that is where the ODs are coming, as you have seen from the graphs I've shown you. The City Council back in 2017, it's March of 2017, basically, as I'd mentioned, had a call to arms and had a public forum. And during this forum, which was extremely well attended, there was just horrible stories, sad stories. And everyone was talking about, well, what the problem is and how we might need to be able to go about solving it. And I was in the audience and listening to a lot of the professionals talking about the pill opioid epidemic. And eventually I couldn't control myself, and I stood up and I said, I'm sorry, I don't mean to be disrespectful to the other professionals in the audience, but we're not talking about the pill opioid epidemic here, because that's not what's killing people. Yes, it can kill people over time. Yes, it's an entry point, absolutely. But what's killing people is fentanyl. That's what we have to deal with right now. And Councilman Gulliford, Councilman Bill Gulliford is his name, said, well, Dr. Pomm, what do you suggest? And out of my mouth comes this thing. And the thing was, we need to start with one emergency department. That is ground zero, one emergency department with a treatment provider. And I'll get into the details of it. Let's not go into every emergency department at first, because it will crash under the weight doing it that way. But let's start a pilot, 6 months, and let's tweak a situation within the emergency department with a treatment provider and come up with the best way possible to manage this crisis from an emergency department, get it right, and by the end of the 6 months, assess its success, and then hopefully by then it'll be generalizable that we can just push it into other emergency departments relatively easily. And that was the beginning of what we call Project Save Lives. Funnily enough, when I thought of the name, I thought that's sort of a weird name, because I'm sure it's very popular. I Googled the name and it wasn't anywhere. So just adopted it. Moving on to slide 35. I'm sorry. Yes, slide 35. We had to be really clear when we started this and not get over expansive with our goal. We are dealing with fentanyl and overdoses. So in order to create a program that was going to be as successful as possible, we had to have a very focused view of what we were trying to accomplish. And that was reduction in opioid-related overdoses, recidivism, and death. That was it. That was our goal. Nothing more. Again, the larger the goal, the more difficult. We only had 6 months to work with, and this was the beginning point. Of course, we needed next slide, a champion. Councilman Gulliford was the champion at the City Council. He was the one that helped push this through, that supported it all along the way. We also needed a champion in an emergency department. It's really difficult to get this kind of program going in an emergency department without someone in the hospital who has respect to the hospital and the authority within the hospital in order to help the hospital understand the need for this. One of the things we realized pretty quickly moving into this was emergency departments in general, even though there was an increase in overdoses, two things became very evident. One was compassion fatigue. Oh, it's another overdose. Oh, geez. I mean, I hate to say it, but this is what I heard. Well, why don't they just die? It's so sad. And when I'm coming forward with a solution, the response is, well, we're just doing our daily job. Whether they come in or not, we're going to do what we do, and we're going to discharge them, called treat and street. And we don't need to staff up for this. It doesn't change anything for us. It was amazing. So the champion from inside first of all, the champion, as I said, Councilman Golford, saw the big picture, saw the need for the city, but the champion in the hospital was extremely critical to realize that, wait a minute, yes, this is an ED, they're coming into the ED, but you know what? It impacts the rest of the hospital. It impacts the bottom line of the hospital. It impacts the city. You can't have such tunnel vision. And this is, Dr. Houston Gilberstadt was our very first champion. And it was phenomenal because I think without him and without Councilman Golford, I'm not sure we'd be where we are today. So it's extremely important if you're thinking about getting a program like this going, having those champions helping you along the way. And of course, the next slide, please. Whoops, I'm sorry, I just pushed the wrong thing. Funding. Trust me, trying to push us, even though it was costing an arm and a leg for the city, trying to bring something forward to the city to ask for money when there was no evidence to back up it would even be successful. And I got a lot of pushback. I remember that meeting for 2 hours. I was before them getting grilled on this whole issue about why would we give you money, because we're asking for over $1.4 million for a 6-month pilot. And was based upon a little bit upon other pilots that were going on, but nothing like this. And it was amazing how much pushback there was. How do we trust you, Dr. Pomm? What you really want us to give you this much money, and there's no proof? No, it's not evidence-based. And I had a look at them, and I said, we're creating the evidence base. If we can't create the evidence base, there never will be evidence base. So eventually they did approve over $1.4 million, and DCF, LSF, Lutheran Social Services Managing Entity for this area, gave us $150,000 per year for 2 years for recovery peer specialists. The project was overseen, whatever it is, by Jacksonville Fire and Rescue. And it was 6 months. It began November 16, 2017, and the pilot ended May 15, 2018. Since then, it has expanded, and we'll get into that in just a minute. If we can move on to the next slide, please. So what would happen is, and let me tell you, at that time, the models were few and far between. But like there was some research that came out, this is again 2017, Yale had done buprenorphine in the ED, and then discharged them. So the follow-up and the treatment and everything else really wasn't incorporated in that study to the extent that I felt it needed to, even though I would like to, at that point, see buprenorphine in the ED. There were other, Vermont had a hub and spoke. New Jersey had actually been doing something in the ED for quite a while with peers in the ED, but it was assess and refer out. That was it. Assess and refer out. Push them out. Push them out. This was going to be different because what I wanted in this pilot was a much greater involvement with the recovery peer specialist in the emergency department and realizing that the minute the addict's feet hit the street, they're going back to their drug of choice. We couldn't let them do that. It needed to be a warm handoff. And so let me get into this. So when a victim comes in of an overdose, while they're being stabilized, the recovery peer specialist was meeting with the family, giving them resources, talking about Narcan, basically, heart to heart with the family and being a support. Then once the overdose victim was stabilized enough, you and I know that when you come out of an overdose and you look at the doctor, you look at the nurse, they don't want to be there. And they're going in such bad withdrawal, they just want to rip the IVs out. And that's what was happening, and take it off and just leaving. And that's what was happening. Here with the recovery peer specialist, someone who's been there, done that, that's one of the first faces they see after the doctors and nurses are done. They're talking the language of the heart and engaging at that level. At that point, we were asking them to consent to be part of the program or not consent. If they consented, then it would be a warm handoff, meaning we transport them, and we still do that to this day, to detox or to the treatment facility. Most have to go to detox first. But that's key, very key component, being with them through the transportation. We actually got to the point where we were so busy, we needed a recovery peer specialist in the detox because the strain on the detox was so great. So we needed a recovery peer specialist because the first recovery peer specialist in the ED had to get back to the ED for the next OD that they had to deal with. And they couldn't sit with them in detox waiting for them to be taken through the admission process. So we had a recovery peer specialist waiting for them in detox so they could hand them off and get back to the ED where they needed to be. Now, we were hoping to be able to give Narcan to the family members and to the individuals that didn't consent in the ED. We were somewhat successful. There's some barriers that we're still working on because the rules that are governed by the hospital, that the pharmacist has to be the one to educate, the pharmacist has to be the one to give it out, and it has to come from their pharmacy, but their pharmacist isn't always there, and they don't have a 24-hour pharmacy. So those are issues we're still working on. We did have a mental health worker there at the time. We realized that probably was not a wise use of funds because the individual wasn't in great shape to do the full assessment, full and valid assessment. And we also had our ED coordinator, who basically coordinated the functioning of the peers in the ED, interfacing with the docs and the nursing staff in the ED. But we realized actually we could have a lead peer, that's where it's evolved, or we could have a lead peer doing that, and it was, again, an unnecessary expense. Realize, again, that this was a pilot. We were there to tweak it, and I'll get more into that in just a minute. All right, so a recovery peer specialist, you're probably all familiar with them. I'm just going to give a short and sweet version of this. These are people that have been there, done that. They're in recovery. We require at least 2 years of recovery. We have peers with anywhere from 2 to 30 years of recovery. The hospital themselves, we need about 3 peers to cover the hospitals. So, as I had said, that before the pilot, it was treat and street. Now, we realized there was going to be some capacity issues coming up. This is now slide 39. Sorry about that. So what we had to do was we were in an interesting situation because, again, most people that go into residential treatment from detox end up being discharged, and they often don't follow up. Here we're in a unique situation where we have a peer who's holding their hand through the entire process. And I thought we can modify our treatment paradigm. So we created a whole new treatment paradigm of 13 days of residential with the understanding that the peer is in pretty much constant contact and support for these individuals, and they would roll right into outpatient. And the curriculum for the residential program would then flow into a concurrent curriculum in the outpatient program, which would be 4 to 6 weeks. So you actually end up having a significant length of time in treatment, but realizing, not just the capacity issue, the most expensive piece is the residential piece, and we have a limited budget. Sounds like a lot of money, but boy, with this epidemic, it was going to be limited both with capacity and funding. So that's how we had to set that up. And by the way, we're still doing that. And the ongoing engagement by the peers was extremely important. Now, what happened in slide 40? We had weekly meetings of all the stakeholders. That was important. We had to tweak it along the way. We had to have our finger on the pulse of everything that was going on in the ED. We had the director of nursing in there. We had Dr. Gilberstadt, who was basically the president of the medical staff at that time. We had DCF involved, LSF involved, and Department of Health involved, because we also had pregnant women coming in, and we had to make sure they were taken care of with wraparound services. We had our treatment people, both at the residential level as well as the detox level. We had to make sure this was all coordinated really well. And it took weekly meetings. So one of the first things we realized that was actually the definition we went into this with was too tight. We were missing too many people, so we expanded the definition. Basically, an overdose was sufficient. Didn't necessarily need to know if it was fentanyl or not, even though we were testing for that in the ED. We just needed to know it was an overdose, and then they would gain entry to the peer where we could consent them into the program. We also realized very quickly that they're not going to even want to talk with a peer if they're in such intense withdrawal. So we actually, I had to meet with the medical staff, and we came up with a comfort pack for the doctors to prescribe clonidine and baclofen, which helped immensely, has allowed the alleviation of the withdrawal symptoms enough where the peer could engage with the overdose victim and try and work with them to consent and become part of this. In the meantime, we added, now the first ED was St. Vincent's Hospital, Riverside in Jacksonville. Then we added Southside Emergency Department. In that meantime, we started noticing a phenomenal shift. Remember I talked about compassion fatigue and how ED staff was like, oh, no, not again. All of a sudden, they started seeing people get better. They weren't coming back. They weren't dying. And we'll get into that data in a minute. And now it's like they could do something. They felt like it was part of it. In the meantime, the peers had become part of the staff. They relied on each other. They worked with each other. And they realized that once a peer was involved, that relieved the ED staff of any further involvement until discharge, the official documentation of discharge. It just was an absolutely wonderful thing to watch as they were now excited that there was something they could do. And it took a while. I was hoping to get buprenorphine in the ED at first. It took quite a while to get the doctors comfortable using buprenorphine in the ED. However, over time, it worked. And now, actually, we'll talk about in a second, several EDs, and they're using buprenorphine, and it works really, really well. Obviously, in this presentation, I don't have time to get into all the details of that, but that's something we can talk about at maybe a future date. One barrier is we were hoping to get the physician certification process of the Marchman Act, which is very similar to Baker Act in some ways, where the physician can fill out what looks like a Baker Act form for a Marchman. It bypasses the need for a court appearance for referral for assessment. It goes right from physician certification to a Marchman Act receiving facility. Then the next step is court, where they are remanded to treatment. Unfortunately, folks don't know what to do with the darn physician certification process, and I'm still working on that. I got to get to Jacksonville. Law enforcement should transport them, but they're not sure what happens, and this is a whole policy and procedure issue. So we're working on that. That's actually next on the agenda with our evolutionary process to get to. All right, next slide, please. That's slide 41. Remember, the goal was reduction of opioid-related overdoses, recidivism, and death. Okay? The outcome, November 2017 till present day. Remember, prior to the pilot, there were 2 deaths a day in Duval County, 2 deaths a day. Since the pilot, it's almost 2 full years now, there have only been 5 opioid-related deaths for those that have been involved in our program. That blew me away. And in that pilot, we only used 1/3 of the budget because the vast majority did not go into treatment, which was really depressing at first. So I realized, well, wait a minute, something's saving their lives. What is it? Well, when they weren't going to treatment, but they consented, our peers stayed in phone contact with them. So all of a sudden now, there was a paradigm. Well, we'll talk about the paradigm shift in just a minute. I'm sorry, I'm getting ahead of myself. But people were staying alive, and it was working because the peers were the linchpin to this, and staying in contact until they wanted to get into treatment. So we only used 1/3 of the budget. Therefore, we were able to expand beyond the pilot. This is just a slide which I'm not going to go into this. It's everything I've been talking about and how everyone's involved. And it's a grassroots community effort. Everyone's got something to do with this. Everyone shares in the problem, obviously. Everyone shares in the solution. And everyone shares in looking at the data and how well this is really going. Just to give you a basic idea, this is as of September 30th. This number is just opiate-related numbers, a total of 1,044. The reality is we now have expanded to all substance-related problems and co-occurring. We have upward of 1,800 now. But those that consented to the program was 611. As I had already mentioned, only 5 deaths caused by opioids. 358 completed it. Total now engaged. We keep them engaged for 90 days from the beginning of consent. Okay, and as you can see, there are now 166 actively involved. Many have completed and have continued to do well. Initial treatment, only 38. Peer support only, meaning they didn't go to treatment. It's just phone contact, still saving lives. Phenomenal as it is. In fact, part of what we had to do was train the peer specialists in motivational techniques that they could use on the phone with these individuals or when they meet with these individuals so they could be truly part of a treatment process, though not traditional treatment process. It's been absolutely phenomenal watching. Moving on to the next slide, slide 44. Remember, only 30% entered traditional treatment during the pilot. And what happened was because the ongoing work with the peers and the motivational techniques being utilized by the peers, eventually in the pilot, 50% entered traditional treatment. All of a sudden, there was a paradigm shift. Now, I'm a treatment guy from way back. It used to be, if you don't get into treatment, you're going to die. Well, that was a sort of a theoretical hypothesis. Yeah, one day you might die, sure. But with fentanyl, you were going to die tonight. I had to back off that. I had to back off the pressure. Because if I pushed them to treatment, they didn't want to go. They were not going to be followed by the program. We weren't going to be able to utilize the resources, the gold mine resources that we have with peers, being ongoing engagement. We were going to lose it. So we had to shift, say, okay, keep them alive. Because if we don't keep them alive, they're never going to get the treatment. They're never going to get the recovery. That became the paradigm shift. Let's keep them alive until they want to get into treatment. And that's what started happening. Totally opposite of what I used to know. And now that's what we're doing on a regular basis. Next slide. 45. One of the issues we found as we've been moving along well beyond the pilot, and was that, and this is really sort of interesting because I mandated that in the ED we were going to split off the urine drug sample, and we're going to send it to a lab to see what's going on. because it was really important. We tested for fentanyl in the actual ED, which we don't do anymore, by the way, because back when we first started this, the fentanyl dips that we were using for instant testing were only fentanyl. And if you remember back a while ago during this presentation, fentanyl doesn't stay long in the system. But now the dips have norfentanyl, which is an active metabolite, and that will stay 2-3 days. So it didn't become as important to test for fentanyl. And there was a lot of pushback from the EDs to test for fentanyl in the ED. So because of the progress we've made, and by the way, I can just say that Premier Biotech was the lab. They donated their services throughout the pilot, and they were the ones that created actually the first fentanyl dip. It's been phenomenal. They actually have a 10-panel confirmation on the opioid analog, on the fentanyl analogs. So we were able to track what's going on, which is really important. And one of the first things we noticed was, geez, 70% of cocaine was being laced with fentanyl. We were finding people saying, I don't use fentanyl. I don't use fentanyl. Well, they are. They just didn't know they were using fentanyl. So, as I mentioned before, 7% of the opioid-using population was Caucasian. Cocaine had been predominantly an African-American problem. Well, now we're dealing with cocaine being laced with fentanyl. It's now creeping into the African-American population. And people are dying from fentanyl overdose because of that. And we're now seeing that demographic shift, which is really, really disconcerting. And it's actually it's impacted how fire and rescue even handles some of these, because, people with cocaine have already a compromised heart from the stress from the cocaine use. And putting them into withdrawal by reversing the fentanyl overdose can put even more strain on the heart. So basically, just keeping them breathing has been an important an important change, so we don't give them a heart attack by reversing the fentanyl overdose because of the cocaine they've been using. Anyway, it's just gotten quite complicated. Interesting also, because we were testing for all this from the beginning, November 2017. It is only now that the literature is starting to show talk about the presence of fentanyl in cocaine. So I'm very proud that we're ahead of the game and being able to look at this. And every ED we go into, we're incorporating this policy and procedure with urine drug testing. In fact, now we're in 5 EDs, and actually we're going to be getting ready to go into the 5th ED coming up. We're opening up 1 ED now, and we're moving into UF Health also coming up in the next month or so. We're actually in the Ascension Health Hospitals at St. Vincent's in the area. We are in Memorial Hospital in the area, and freestanding Memorial Hospital ED. We're now officially opening on Monday in a Baptist ED, and we're moving into UF Health next. So it's become, and the successes are still happening. It took the first to be successful, obviously. Now, here's more problems, and that is we're now seeing that it's not uncommon to find individuals to have positive drug screens for cocaine, methamphetamine, fentanyl, marijuana. And many of these individuals say they don't even use fentanyl or heroin. It's cocaine, methamphetamine, marijuana are being laced with fentanyl. We're in our detox seeing a lot of psychosis. We're becoming a behavioral ICU. So where you think it was bad before, it's just getting even worse as we move along, as fentanyl is being incorporated into all of the drugs of abuse. Just to show a little bit of that, I'm not sure if you can see that, but you can see cocaine is 72%. We're seeing positive in these OD victims. Just to highlight something, I want to show you that the gabapentin is being abused too. And there are several issues around that which we don't have time to get into, but I try not to prescribe that because of its abuse potential. you can see at this point 30% are positive for benzodiazepines. So the use of benzos has come down some. However, it's still a significant problem because when you add a benzodiazepine to fentanyl or opiates, the likelihood of overdose is heightened greatly. Next slide on 48. Sorry. We're not, I'd mentioned phenylfentanyl, which got to the Midwest but didn't really get to us much, only 3%. But we're seeing acetylfentanyl now. And that's something most people have never even heard about. The more I talk about it, they still haven't heard about it. Black market folks realized something, that their business model wasn't really good, because what they were doing is they were killing people. Well, it doesn't, killing your customers isn't a great business model. So acetylfentanyl is about 5 to 20 times more potent than heroin. Remember, fentanyl is 50 to 100 times more potent. So what they're doing is they're diluting fentanyl with acetylfentanyl, which is keeping them alive, more easily reversed by Narcan, but keeping them addicted. And we'll get a little bit more into that in just a couple of minutes. I'm going to go on to the next slide, which is slide 49. And we're still seeing some use of oxycodone and other opioids, but I want to go into the next slide, which is 50. We're still seeing quite a bit of Xanax. Interesting, we're seeing more Klonopin than I've seen before, and I don't understand that. We're just sort of following these trends as we move into 51, and that's been a huge increase. Oh my gosh, 95% positivity for amphetamine and methamphetamine. That is just insane what's going on right now. Let's make it even worse. Don't need to be depressing people, but I want to be real with everyone here to make sure everyone understands what is killing people, what we're dealing with today. Yes, there are fake Xanax pills out there. They're actually fentanyl. You take it, you die. There are fake oxycodone pills out there. You take it, you die. This is where a lot of the fentanyl is coming from. This is not an advertisement for Ching Labs, okay? This is where it's coming from. And it's coming from there and coming up through Mexico and being mixed in either in Mexico or locally by the dealers. When we have another nation that is a potential enemy who is sending chemicals over to our country that is killing people in greater numbers than any war has ever seen, I call it chemical warfare. I actually spoke with a U.S. congressman about that. He said, well, I can't call it that because then we got to do a whole bunch of other things. But, that is what is going on. And unfortunately now, because it's being mixed in with so many other drugs, we just had a bust not too long ago in our local area of marijuana that was laced with fentanyl. So, unfortunately, where we're at now, and the new message that has to be transmitted to everyone that we come in contact with, no matter what age, recreational drug use is now lethal. And that is not an exaggeration. That's slide 57. If you get nothing else from this presentation, I hope you take this one home. And literally home. We're seeing people down to 8 years of age who are being victims of this problem. Okay. I want to go back to this slide 58 now, the same slide I showed you before. Remember we showed you the increase as history through the slides has shown you. It started in 2016 and continued to climb, and then it dropped off. And you can see it dropping off in 2017, only to climb again. So why? Whoops. Sorry. Pushed the wrong button again. The drop. Not because of Project Save Lives. Yeah, we were being successful, but it was a very small number of people we were actually engaging. I believe it's because so many of the samples being used, the drugs being used, were laced with acetylfentanyl. Now, remember, I said it's 5 to 20 times more potent than fentanyl. Than heroin. Remember, fentanyl is 50 to 100 times more potent, very lethal. Acetylfentanyl, 5 to 20 times more potent. Yes, potentially lethal, but with the tolerance factors already built in to their drugs, the individual's drug use, people aren't going to die as readily, and they're going to be reversed more easily. So with an increase in acetylfentanyl, they're not dying as readily. That's what I believe is the biggest reason for the drop-off, okay? Now, also, we've had an increase thanks to the government giving us more money in buprenorphine. So, but the buprenorphine numbers still aren't that great either, but you put the buprenorphine numbers with the acetylfentanyl, I believe that's the biggest reason for the drop-off. And if you want to go back now, go backwards to 58 again, please. Now it's starting to rise again. See that? Why? And City Council asks me this. I report to them all the time. They ask me, what the heck is going wrong here, Dr. Pomm? Well, that's when we started seeing the inclusion of fentanyl in cocaine and methamphetamine and marijuana. So it's coming back in other drugs, hitting far more population than we ever have had. And moving back to slide 59, that's why the rise. So here, the drop-off was a hope, but no, wasn't a hope. It was a reprieve, but not the best way to get a reprieve. And now the rise, it's becoming even more catastrophic. Moving on to slide 60, there is some really good news. And moving on to 61. So we actually have, for those that have been engaged in Project Save Lives, we have had a overall 66% reduction in recidivism, meaning that they're not coming back into the emergency department. They're not overdosing again. If you break that down on slide 61, you can see that there's a 71% reduction in overdoses. Now there's a 51% reduction in other 911 calls that addicts typically run into, falls, back pain, et cetera, that bring them back into the ED. So it's impacting various levels there of returns to the emergency department. The other very exciting data, which is on slide 62, I'm sorry, I keep pushing the wrong button on my part. Endocarditis is inflammation of the heart, the inside of the heart, actually. So what happens is most endocarditis cases, greater than probably 99%, when a person's injecting, it's often not with a clean needle, and they inject bacteria into the blood system. That bacteria seeds itself in the heart, the interior lining of the heart, and it's a very difficult infection to treat. In fact, it can take up to 6 weeks of IV antibiotics and a long hospital stay to the tune of greater than $50,000 for a hospital stay. Now, if it gets too bad, it can actually affect the valves of the heart, needing valve replacement. Now you're talking $200,000 to $300,000 for that. So I asked Dr. Gilberstadt, I said, okay, knowing that endocarditis is mostly caused by IV drug use, let's take a look at how Project Save Lives might be affecting your endocarditis data for that first hospital where we began November 2017, St. Vincent's Riverside. So that very first quarter where we were starting, just sort of getting our feet wet, they had approximately 106 endocarditis cases. That was called the fourth quarter. That's the first number. That's the first quarter we were there. The next quarter had already reduced to 90 endocarditis cases. That following quarter, 63. And the last quarter, that first full year of Project Save Lives, it dropped all the way to 28. That was thrilling. That was very exciting. Now we're going to be asking all the ADs and hospitals to follow that data in their own hospitals. We don't have that yet. Moving towards the future, I mentioned Hospital 21 at the beginning of this presentation. Just very quickly, it does limit prescriptions. You can look up the bill. It does limit prescriptions. And as I said, it was a little late. We should have had that in the late 90s, early 2000s. But we need a lot more. Nothing speaks to the fentanyl epidemic in that bill. Now, one of my concerns I expressed to the Senate subcommittee was, look, when you take these people that have been getting massive quantities of pills from the doctors and say, you're no longer going to be able to get them, what's going to happen? Well, guess what? They're going to return to the streets and fentanyl use. As I say that, I'm just thinking now, I'm wondering if that has something to do with the rise too, and we're going to have to do some analysis on that. Also, the feds have released money that was originally approved by the Obama administration for STR and SOR funds, which we don't have a lot of time to get into, but it's really funding a lot of treatment and medication-assisted treatment, which has been a really, really good thing for everyone. Of course, one of the concerns we have is what happens if that money dries up and we can no longer get people on buprenorphine and keep them drug-free and keep them away from overdoses. What happens when if that money dries up, then we're at a cliff, a precipitous cliff, and I hate to even think what would happen. So hopefully that money will continue to flow and maybe even expand as we're seeing the successes because of that money and what we're doing with it and how helpful MAT, medication-assisted treatment, has been. Next slide, please. To slide 65. So we will have 7 emergency departments by the end of the next fiscal year, capturing 80 to 90% of the city's overdoses. I already mentioned about the Memorial Baptist and UF Health. We now have opened it up from just overdoses to substance use disorders and mental illness. We are actually now, because of another grant through the CDC, expanding peers both in detox as well as in the hospital floors. People go from the emergency department into oftentimes if they're admitted to go to the hospital floor, the peers try and follow them on the hospital floor, but they're also needing the ED. That's been a real challenge back and forth with this new money. We're now going to have to staff peers on the floors so the peers in the ED can be focused on the ED work. We actually have had to, because of capacity issues, expand to other treatment providers, even the for-profits, and they've been working well, giving us some scholarship beds. So that is continuing to be tweaked and worked on, but it's a community problem. I mean, everyone's affected. So we do need partners, and that's exactly what we've been developing, and I'm very hopeful about that. Housing, we've been working with housing, and again, we've developed a network for housing, and that's been expanding. And again, being a community problem, if they don't have housing, it's going to be a problem. That's what we're working with. We meet with housing for the area on a regular basis, as we do with the treatment providers. We're also getting ready to push out an education piece through Project Echo. Don't have time to get into that, but that's basically actually an international platform where we can get to lots of individuals and educate them on the problem and also potential solutions. When I say people, I'm talking about our professionals, talking about our law enforcement, talking about fire and rescue throughout the country. And so we're excited about the possible beginning of this, which should be sometime early part of next year. And the next slide, the barriers. This is the last slide for this talk. There's been some pushback with the 12-step community about buprenorphine, and we're reaching out to them. We're meeting with them, and they're opening their eyes and ears to this, realizing that, our goal is to get everyone in recovery, but they got to be alive first. So that's been important. Got to keep them alive. And if we tell them they can't be on buprenorphine, they're going to die, unfortunately, or MAT, they're going to die. Let's keep them alive, and let's work with this. And eventually, people do come off buprenorphine. But helping them get in recovery is key to getting them off buprenorphine eventually. And that's been working really, really well. There was some pushback from recovery housing, and that's working well too. As I mentioned, how long keep people on buprenorphine? Well, when they're ready. Take them off before they're ready. Guess what? They're going to relapse. So they got to get in recovery. They got to work a program. They've got to be able to live life on life's terms without drugs and financially stable, relationship stable, job stable, housing stable, learning how to deal with stress. When they're ready for that, then we're ready to move on. Unfortunately, I do have concerns about funding. We're capacity issues with detox, and got to work on that. I'm not sure what the answers are with that. And just to say that, only 15% of the ED referrals have commercial insurance, approximately 25% have Medicaid, and 60% are indigent. So getting funding for all these services is extremely important. And a lot of barriers, but there are some potential solutions. It's just everyone's got to get together. I'll be honest with you, if every community got together like Duval County, like Jacksonville, if every community got together and made it the community solution based upon the community problem that it is, I think we could really, really, really have a huge impact on this epidemic. And with that, I think there might be time for just a few questions, and thank you so much.
Yes, we only have time for one question, and I would also like to, if it's all right with you, to hand out your email in the in-chat if anybody has any follow-up questions due to our delays.
Sure, that's fine.
All right. Dr. Dudley asks, is there a country or geographic location that is more prevalent in supplying drugs?
Yes, drug supply, a very interesting question. The fentanyl is coming from China. There's no question about that. They don't have a problem, by the way, with fentanyl. We have the problem because of them. And Colombia is bringing a lot of the heroin and cocaine in. And in fact, I can tell you, I met someone from Venezuela who said to me, on the border of Colombia, a barista at Starbucks. Funny. Anyway, it's my addiction. So she asked me what I did, and I told her, and they said, we don't have a drug problem in Venezuela. Why? Because, if we use drugs, we get killed because we're cutting into the profits of the Colombian drug cartel. So interesting. That was sort of profound at the time.
All righty. Thank you very much, Dr. Pomm. Thank you for our listeners for bearing with us through our technical delays. I'm going to go through the conclusion now, and that will be the end of our webinar. Please note a couple of items of business before we conclude. When I conclude today's webinar, your web browser will take you to an evaluation on FATA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for FLA licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign on, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up a profile in FATA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx. Evaluations will close at midnight, November 18th. As a side note, sometimes that email does not get through, and if you simply click on today's event on FATA.org in the calendar section, there will be a button that says Take Survey. We do not email statements of credit. Instead, afterwards, we verify attendance and completion of the evaluation. A statement of credit will be generated as a journal entry within your profile. And thank you for participating in today's webinar. We'd also like to thank especially the Office of the State Court Administrator for funding today's education. Have a great rest of your day, and please hold on for the evaluation.